Welcome to session number 27, the digitalized patient experience, how novel digital therapeutic data will reshape your analytics and remote patient care programs. That's a mouthful, but I think it's going to be great. Please open up your polling application, and remember, if you want to submit a question, that you do it through the application, and then audience members will vote on those questions, and the ones with the most votes come to the top. Remember, you can score points when you participate in the poll, and submit a question or vote on a top 5 question. And if you have any questions about the app, raise your hand now, and we have technical support in the back to help you. Okay, let's start by having you get an idea of who you're sitting with and have the panel understand who they're going to be talking to today. And we're going to turn the time over to Steve Bowen, who is our analytics analyst, and he's going to share some insights on the audience today. Steve?
Hi, good to be here. So today, this is no surprise, as probably most of your sessions look the same way. Mostly IT analytics folks in here today. Some clinical operations, and very little finance, so you're in the minority today. I did want to share one other view today. This question, most of you answered, which of the following options is the biggest obstacle in shifting from charge master costing to true activity-based costing? And this was the biggest variance to the conference in general. Seems like most of you think it's a significant financial investment, or finance department is entrenched and they won't change. Just a little interesting tidbit for you to start off the day. So with that, we'll turn it back over to Kathleen.
Okay, thank you. I'm very pleased to introduce our panel today. We're going to start with Carlos Rodarte, who is leading the panel, and he is currently the Senior Vice President for Life Science Strategy Business Development at Health Catalyst. He also led efforts at Patient Like Me in discovering digital biomarkers and validating digital therapeutics across patient populations, and he participates on several advisory boards and is an internationally recognized speaker on health innovation. Next to him is Chris Hogg, and he is the Chief Commercial Officer for Propeller Health. He's a digital health advocate interested in new forms of data and how they are changing the relationship between physicians and patients. He also founded 100 Plus, a mobile health company which uses personalized analytics to promote healthy behaviors. And he has also led a cardiovascular commercial strategy group at Gilead Sciences. Next to him is Mette Dyhrberg, and I'll have her give you the Danish pronunciation of that later. No, I'm sorry. I hope I did.
No, that's fine.
I hope I said that correct. Is the founder and CEO of Mymee, Inc., and that is a digital therapeutics platform rethinking autoimmunity. She holds an MS in economics and is a certified health coach. And she first entered the functional medicine arena in an attempt to tackle her own chronic health issues. Mymee is built to support iterative health improvements for the individual, and as an authority on autoimmune issues, Mette speaks regularly on how we reinvent healthcare for autoimmune disease. Our next panel member is stepping in for Eddie Martucci, who was unable to be here, but we appreciate Matt Omernick standing in for him, and he is the co-founder and creative officer at Akili Interactive Labs. He has a background in games, film, and television, and as an executive art director at LucasArts, which is the video game division of Lucasfilms, and at companies also like DreamWorks and Microsoft, he oversaw studio-wide art team on multiple projects. He teaches and has taught computer graphics at Cal State, the Academy of Art University, and at the Art Institute of San Francisco. And he has written a book called Creating the Art of the Game, which is a standard in the industry. And lastly, we have Owen McCarthy. He's MBA, and he's the co-founder and president of MedRhythms, Inc., which is a digital therapeutics company that uses sensors, music, and AI to build evidence-based neurological interventions to improve walking and allowing patients to regain their independence. He has an MBA from Harvard Business School, and he also serves as a co-chair of the reimbursement working group at Digital Therapeutic Alliance. So as you can see, we have a very interesting and diverse panel, and we're looking forward to hearing from you.
That sounds great. Thank you so much. We're really looking forward to having some lively discussion. This whole panel session is focused around digital therapeutics. So maybe right off the bat, we can take a quick little poll. So get your apps ready and your thumbs ready to push some buttons here. But how many of you are familiar with evidence-based digital therapeutics? So we'll give the audience a few minutes here or a few seconds maybe, to reply.
Real time.
Yeah. And then you can let me know when we have critical mass back there. Wonderful. I love it. Prepare to have your minds blown. This is great. So I think just to set the stage a little bit here. As we start thinking about the objectives, one of the first things that we want to make sure that we achieve is that everyone walks out of this room knowing what a digital therapeutic is. So I think it's going to hit on that 55% pretty nicely. We'll talk a little bit about how a range of diverse data sets are actually enabling a wide array of different patient experiences and really redefining what a therapeutic experience even is. And lastly, and to the extent that we have time, we'll hit a little bit around some of the clinical and regulatory challenges that these companies are facing as they go to market in the context of some of the challenges that the industry is facing. So I think that's kind of what we're doing from a learning objective standpoint. We'll spend about 5 minutes or so having Matt give a little bit of a primer on some definitions around the industry and the range of companies that exist, and then we'll dive right into I think it'll be about 30 minutes of actual panel discussion and 15 minutes of Q&A. There will be another poll towards the end of the session, so keep your phones out. But with that said, I'll turn it over to Matt.
Good morning, everyone. All right, so what is digital therapeutics? It's a very good question. Here's a couple definitions, and I'll attempt to give you a couple of kind of my perceptions and the way that Achille thinks about it, and many of the people on this panel I think are going to have a slightly varied definition. It's a term that's been around, I would say probably close to a decade now, but I would say it's only been the past couple years that it's really started to form and become clear really what we're talking about when we describe a digital therapeutic. So on the left up here, this comes from the Digital Therapeutics Alliance. DTX, for short, often you will hear, refers to evidence-based therapeutic interventions to patients that are driven by high-quality software programs to prevent, manage, and treat a broad spectrum of physical, mental, and behavioral conditions. Alternatively, you can think of them on the right over here. This came from Cowen. Digital therapeutics represent a potential paradigm shift in the way that disease is treated as the software itself starts to become the therapeutic. So the key word that we kind of hone in here is software. It doesn't mean that hardware is not involved. It definitely is. But another way to think about this is you can almost think of two very simple buckets. Using technology, using software to look at existing ways that we treat people, right? Looking at healthcare and the existing kind of medicine, the way that it functions now, and using that tech to see how we can improve that and make that better and make that more efficient. That's kind of one bucket. And then there's using that tech and using software to create entirely new modalities and looking at diseases in an entirely different way. So a lot of what digital therapeutics is trying to do is question the way we've done things in the past. And oftentimes we've done them right and we can just make them better. And oftentimes they're a little behind the times, and there's things that we can do now, that we have capabilities now that we've never had before to be able to really push and help the patient in ways that we've never imagined even 5 years ago. So really think of digital therapeutics as software and hardware in service of the patient in new and exciting ways. This would help a little bit, I think, paint the picture that this is a already large industry and growing exponentially. If anyone's seen any of the projections, digital therapeutics, digital health is going to be very massive, and it's already getting there quickly. It's a very diverse group of companies, and you can see this slide describes a whole bunch of different ways to look at this, but there are digital therapeutics that are designed to prevent medical disorders, to optimize medicine, and to directly treat, and many categories within. So the diversity and the variety and the nuance of what a digital therapeutic is pretty complex, but everything we talked about before, I think, is the common thread between all of them. So given that, I think we're going to be able to dive even deeper and get more information as we just field your questions. So,
That's great.
thanks.
Thank you. Thank you so much. One of the things that you mentioned, kind of a new paradigm. When you think about traditional drugs and devices, you view it as something that you ingest into the body, and you get a blood draw, or you do a patient-reported outcome measure, and you figure out whether that thing worked. I think what we're talking about here is the measurement modality, and the actual therapeutic intervention is one and the same, and really integrated into human behavior in a closed feedback loop type of approach, which I think is really amazing. So I think we have such a stellar set of panelists, each having a very unique approach to the way that they think about the market, but also their technology. So maybe the first question off the bat, and we'll go kind of down the line here, is how do you describe the components of your digital therapeutic solution, assess whether it works, and how did you choose some of the diseases that you decided to pursue? And maybe Chris, I'll go ahead and start off with you.
Sure. So Propeller is focused in respiratory disease, so asthma and COPD. And we make sensors that go on inhalers so you can collect passive data on how people use their medicines. The reason it was respiratory was out of the founder's interest. He was a PhD epidemiologist working at the CDC and very frustrated with the level of data that was available on how people were experiencing asthma and where in the community, and so started building. And so the components for us, we have hardware, so sensors that go on inhalers. We have apps for patients or their caregivers. We have data integrations and feeds, and then dashboards that are for care teams who try to use it for management of remote patient monitoring to see who's not doing well. So our solutions kind of broke it up into two. There's what we would call a digital therapeutics component, which is the sensor and app for self-management, and then also a clinical monitoring piece that integrates hopefully back into clinical workflow.
That's great. And I think the ability to look at sort of environmental triggers and knowing sort of like how space and environment relate to disease management is super cool.
Yeah, we can learn a lot. We can pull in, because we have it on the phone, we can pull in weather data, pollutant data, pollen data, wind speed, all things that might impact a person's disease. And really through modeling, machine learning, you can actually start to see for an individual what might be causing their symptoms and give them alerts. We can forecast with pretty good fidelity the risk of a certain person using their inhaler on a given day or not, and then use that to try to help them better self-manage.
I love it. Great, thank you.
Yeah, so at Mymee, we address autoimmune disease. So we're really into the game of detecting triggers to understand underlying why the body is attacking itself, and then through behavior change, getting rid of the symptoms, and a lot of time medication altering. I think from just an outside perspective, it's like three components. It's the app for the self-reporting. It's a dashboard that leads health coaches in the behavioral endeavors. And then it's computational algorithms on the backside to actually understand the patterns and the algorithms to what is it that goes into producing the disease. In my case, I was the N of one. I, over 20 years, accumulated 6 autoimmune diseases. And in 16 months in an Excel spreadsheet with a couple of algorithms, I reversed all my disease symptoms, got off all of my drugs, and have been symptom and drug-free for next month 8 years. So for me, it was really a matter of seeing my 20s and 30s flush down the toilet and being able to reverse it, and seeing that there's really no way in the market right now of addressing autoimmune disease as a process. So a little bit more like an engineering approach to the body, but that's what we're working on.
At Achille, there's a reason that someone from the entertainment industry is sitting up here amongst these much smarter than I people. So at Akili, we're building direct digital therapeutics that look and feel and act like a consumer quality video game. And they are built from the ground up to address specific neural networks in the brain. And the disease areas that we focus on, our first product is going to be for pediatric ADHD. followed by a long range of different cognitive disorders. So things like MS, depression, anxiety, autism, the list goes on even to things like traumatic brain injury, areas that we feel that we can use software to improve and to help rewire the neural network in these different areas of the brain. So what our products actually look like I said, our core treatment, our direct treatment is, in the case of pediatric ADHD, really indistinguishable from any high quality, real-time consumer game that a kid would play, where you've got dozens of 3D worlds and character customization and tons of rewards and connectivity. So we have an entire game team that is full-time at Akili that come from many of these big studios to develop really high-quality products, because we believe the engagement, and we know this from the science, the deeper the engagement, the more potent the effect. So our core treatment, direct treatment, looks and feels like a game. And then we have companion applications, not unlike what you guys are describing too, which are for the caregivers, the teacher, parents to be able to input symptoms, behaviors, and track and monitor the child's progress. So on one hand, we're directly treating the patient, and we're learning a tremendous amount through data about the disease, and we're getting feedback on these symptoms and behaviors sometimes multiple times a day versus once every 3 months in a doctor's office, for example. So that is the short version, believe it or not.
And I think what Matt and the Akili team have done tremendously well is they've given every child, hopefully in the world, the best defense to parents saying, stop playing those video games. So thank you for that. Owen, over to you.
Yeah, great. So at MedRhythms, we really focus on neurologic injury disease and helping people improve their walking. And how we got to this point is my co-founder was a clinician at Spaulding Rehab, trained in neurologic music therapy, which is a fairly niche field. And there's an intervention within that called rhythmic auditory stimulation that's been studied across 50 plus studies, RCTs, et cetera, that shows how rhythm improves your walking speed and balance, and you can put this intervention into that. What Brian was seeing, and came to me when I was at business school with, was he was one of the only people in the Boston area trained like this. People would leave Spaulding Rehab and say, how do I continue to get this kind of care, like on a daily and weekly basis? And that's really the question we started the company around. And so the manifestation of that is our digital therapeutic, which has sensors that go on people's feet, measure everything you need to know about walking in real time, feed that into a phone where we've pre-screened music for rhythmic content, and we can use preferred content, preferred music, and change that to deliver rhythmic auditory stimulation back to someone, and then drive them towards a clinical outcome. And so our first product we'll be launching is in the chronic stroke population. In that population, we look at endpoints like anyone else would in walking in chronic stroke, improving walking speed and balance using sort of some standardized metrics for that.
That's great. And I think it could be any song, right?
Almost any song.
Yeah. That's great. So I think, as you can see, there's a wide diversity of companies up here, slightly taking different approaches. We'll get into some of the clinical validation. Before we get there, one follow-on question to that is, you're going after such different patient segments that are used to such different experiences. Some are in the inpatient setting, some are in underserved communities. There are people that have had autoimmune issues for so long that they're just devastated that nothing seems to work. Pharmacological options haven't really been that great. There's some real human elements here of people looking for novel solutions. So I'd love to kind of get a sense from each one of you. How do you think about patient engagement? And how do you leverage that data to really empower and activate individuals in the context of self-management? And maybe Chris, I'll start off with you.
Sure. I mean, we look at engagement has a lot of buzz, and a lot of people just want to look at an engagement number when we do programs. We look at it more as a tool. We have to engage people when we need to, when we know that they're not doing well or that they need an intervention. But if somebody's doing well and they're taking their meds and they're not symptomatic and they're pretty well controlled, like, we don't want to pull them into an experience and remind them that they have asthma or COPD. And so it can go wrong, and we're seeing that in the tech community now with a lot of trends around, over-engagement. And so we're trying to put to bed this myth that, you have to have someone in your app every day. It's just a tool, and you have to get really good at firing it up when needed and letting it go down when not, and then just fitting into their normal life. Like, nobody wants an app. It's not like Instagram. Nobody wants an app that's just pounding them every day, reminding them they have a disease and asking them about it. And so you have to be really, really delicate and figure out where are the right insertion points and how do I do it with what tone and what language, but not overdo it.
Yeah. I think in Silicon Valley, they used to have this saying that your product had to be 10 times better than competition. And in what we do, they have to be 10 times lighter. It literally is how little touch can we have, but still have the impact needed. So in our case, we need data to do what we do because we need to understand the triggers, and without the data, we can't do anything. But we've gotten it down now where it's less than 3 minutes a day of engagement, but it's a very different kind of engagement because we don't ask people for everything they've eaten written out or caloric intake or anything like that. We've actually tailored the language around them. So on the back side, our system has clinical language, but on the front side, it's tailored to the individual. So an example is right now we're doing a chronic pain study with Cornell, and they want mild, moderate, and severe pain. Well, to the patient, that makes no difference. But if it's mild is achy joints, moderate is mobility issues, and severe is I can't get out of bed. I've never had a patient not being able to get out of bed and not being able to distinguish that. So we actually make it very clear in the app, and around tailoring it, you basically just have very small touch points, and that allows the patient to gather the data without it being cumbersome. And I think it's an extremely important part is what is that we're looking at and for whom? Because I think a lot of times, every time we've had a doctor look at the backside, they'll come up with 10 things they think we should add. And I'm like, that's great, but we really built this for the patient, and I think because it was a company that was built by patients, it's patient-centric, and I think that's what has created the success. So in our latest RCT, we had a 93% engagement, and we've never had anyone go through the program that didn't get improvement, and we were extremely disappointed. And people were like, what are you talking about? We're like, well, when we go to a health payer, we typically have 96% compliance. So for us, compliance is something that we've literally obsessed about for 8 years. And I think if you want to make it in this field, you have to obsess about it.
Yeah, that's great. I'm glad you mentioned compliance because the word engagement, as you guys are suggesting, has a lot of meaning, a lot of different meanings, I should say, and it's used in different ways. There's kind of 3 ways at Akili that we kind of break up engagement or think about it. One is compliance, very specifically when we run our trials, right? There's that kind of engagement to making sure that patients are staying on task and complete the trial. So there's compliance is definitely a type of engagement, right? Related more to a kind of a second bucket, which is retention, which is something that is used a lot in the mobile gaming space and mobile apps. A lot of companies are trying to keep your eyeballs in that app for as long as possible, as frequently as possible, every single day, and that's often referred to as retention. And then there's the third type of engagement that we break out, which is specific to the game side of things, and you can think maybe an interchangeable word there is immersion. What we do know, about the brain, which is still very little, everyone knows this, is that it's experiences that do change the brain. Sometimes good, sometimes bad. In the case of PTSD, for example. It turns out that video games are an incredible tool to be able to create an experience. And they're a tool that can be highly adaptable and customized and really, really bring someone into the immersion factor. So we've learned to kind of break out engagement into kind of those 3 things so that we don't mix messages when we're talking about it even internally. So that's our take on it.
Yeah, and what's really interesting there is I think being really practical, the notion or the premise oftentimes is that, if someone is on a medication, for example, could you actually see some benefit in the way they perform the game as well? Or, how do you actually dynamically adjust the complexity and difficulty of the game to sort of keep people engaged and still reach some level of therapeutic value? So there's a lot of really interesting components that have come up in our conversations recently.
Yeah, I don't have a whole lot extra to add, but as we think about it, our intervention has a dosing and a frequency requirement. It's 3 times a week for 30 minutes. And so, when we look at compliance, that's what we're looking for. We are in the middle of our pivotal trial right now, so it's pre-market, so we have some hypothesis on how to improve engagement and, have learned a lot from other folks that have been out into the market like Chris, et cetera, about how to do that. But it's definitely really important for these products going forward.
Yeah, absolutely. And I think a lot of the criticisms about digital therapeutics is often that it's technology or it's a video game, and how can that possibly be effective? How can you reach some meaningful clinical outcomes? So maybe we can spend a little bit of time talking about some of the evidence that's been generated. And I feel like now with the regulatory pathway emerging, that's come more to the forefront. But the reality is that a lot of the companies here have prioritized that from day one, and have thought about evidence in a number of different ways, because you're going up against drugs. You need to convince physicians. You need to ensure that where they're going to be used. So I'd love some tidbits around how you've thought about some of the evidence, and maybe we'll start from Owen and come back this way.
A little bit, yeah. So we prioritize this from the beginning. We're taking an FDA-approved prescription approach to the product, and for a improvement claim in the chronic stroke population. And so for that, we have leaned on some of the rhythmic auditory stimulation research. We ran a feasibility study earlier this year, looking at improving walking speed over a certain period of time in the chronic stroke population. Why we cared about that was two things. One is that's an unmet need. Right now, they are believed, if someone has chronic stroke walking deficits, it's believed they've plateaued and there's no regular intervention for them. However, they're still often confined to their homes and can't go out in the communities. And walking speed is directly tied to being able to do that. Two is and we're actually working with Health Catalyst on this a little bit, there's some really good evidence showing if you improve walking speed, you lower fall risk every 0.1 meters per second by 7%. The VA did a study that shows you lower annual medical costs by $1,700 for every 0.1 meter per second. So it's one that we care a lot about, both from a clinical side and a commercial side, because and from a patient side, if someone can literally leave their house and walk across the street or be independent again, it changes their lives. And so it's meaningful in three ways for us.
That's great. I'm looking at this array of companies up here, and there are many more, but the majority, I would say for sure, up here have another task, whether they like it or not, is we're trying to actually legitimize a new industry, right? So really putting our best foot forward on clinical rigor and validation, setting really high standards across the board is something that we've all kind of agreed upon that we need to do to distinguish this very potent, very exciting new medicine, and this kind of really a big change to the way that healthcare is administered, to get it right and make sure that's clear in everyone's eyes that it's correct. So it's an additional, with great power comes great responsibility and great pressure, but I think that we all feel that, and we all take that very seriously.
Yeah. I also think that making sure, I don't actually care if the patient gets help by drugs, by our product, or something else, or a combination hereof. So when we go into RCT trials, in this case, we've just gone through pre-submission for our lupus protocol with the FDA, and for lupus, you have mortality. There's a lot of things involved in lupus that makes it a lot more complex. So instead of just saying, we know everything, we actually had pharma companies, we had a lot of other companies look into our protocols and say, well, if we had done this, our rigor would have been like this. And we're like, okay, so we're testing it. Because to us, if we can't measure up to what the world have sort of said, this is the standard, then it doesn't matter. But that being said, there's actually no side effect to our product. So we're already selling in the market. There's no requirement. The health plans that come to us, they don't go, have you gone through FDA on this? They're like, just give it to us, because they're saving money on a daily basis. But on the other hand, we know that FDA will give us a completely different market, and I think that's how a lot of us are thinking about it. How do we both implement rigor, but also actually get to the patients so that we can create data? Because like you, we've actually shown organ involvement, things that have not been shown in medical literature. We've only had 700 people through. So it's pretty remarkable what you can actually do.
Yeah, I just wanted to underline that part. I think it's all about getting it to the patient, right? And that is the most important thing by far.
Yeah, the only thing I would add, we were similar. I think we were pretty lucky that Propeller had a lot of academic and medical research geeks at the beginning, and so it was sort of obvious to us that we had to study it in the right way. And we have 23 publications now on different things. The problem for us, though, is that there's never been enough. We keep publishing. We've had customers now publish in outcomes data, hospitalization data in asthma, COPD. There doesn't seem to be a threshold at which now you're done, and now every health system is like, great. It's still, and a lot of that is because of the uniqueness of these types of interventions, that the implementation it plays a big role in the impact that your intervention can have. And so now we focus a lot on what we're like implementation science. What's the best way to implement these things? Because we sort of batted down the clinical, the clinical evidence is there, and now it's can we repeatably scale it out in different systems, because it's still every one by one by one.
Yeah, so we've had kind of this running joke for years now, right? Which is like, you develop evidence, you're working with a health system or a provider group, and you show benefit, and then you go to the next one, and they're like, well, no. See, our population is different, and it's just sort of this reinvention of the wheel, which in some ways, if you think about drugs and devices, when they gain an indication, it's a question of whether they're part of the pharmacy benefit, what have you, but it's pretty well defined in terms of where they're going to fit on the treatment paradigm. So I think there's some lessons to be learned as we think about what's worked well on the drug side, and how can we optimize for the digital therapeutic side. So we have about 7 more minutes. I have a couple of more questions, but start thinking about some of your own questions, and particularly the tough, challenging ones that will stump the panelists. They've been through the trenches and have gone through a lot.
We'll send them all to Matt.
Yeah, we'll send them all to Matt. He likes this tough questions. But as we and you started to right, and you started to hit on it, Chris, which is some of the barriers to actually enabling adoption, and there's certainly barriers to the patient side. It's sometimes new behaviors that they're not used to. Maybe I can't think of any patient really. I'm kind of lying because I know Owen and kind of what they do, but listening to music and saying, wow, I really am going to dose my music, for 15 minutes or half an hour, and really feel better. And here's how I'm going to measure that. Mostly, it's like you put on the Beatles and you're relaxing and you feel better, but you haven't thought about it that way. So on the patient side, that's one element. On the provider side, what have been some of those challenges? Do they not believe the evidence? Do they think it's too hard to implement? What are some of those initial learnings, either from research studies or from the actual care world?
So it's all of the above. Being a digital health entrepreneur is, you have to be an eternal optimist. We were talking about this last night. It's been very, very hard. Our CEO has a good expression, we're the double black diamond of startups. Like, everything we do is hard. You have to get patient behavior and doctor behavior and integrate into systems. But the big challenges have been, we've gone through a series of steps where, honestly, 10 years ago, a lot of us were doing this, and you were joking that we had 2 heads, and people would look at us like we were crazy. They didn't believe you could build an app or a system that actually improved a meaningful clinical endpoint, and then you couldn't prove it, and we've just done all these things. And now, when you think about a drug gets approved, it's sort of magic. It gets an NDC code, and that makes it show up in the ERX list, and the doc knows to go there, and it magically goes to the pharmacy, and everything just works. And none of that works for us. And so a lot of it's building the rails. You can spend all the time proving it. The clinical data are there. This doctor wants to use it. What do? There's no place in the EMR that this lives. The data doesn't magically get back into the EMR so that they can add it to other data that they have and use it effectively. And so we're just slowly building the rails of this new type of intervention. And that's been the biggest block, honestly, is that you can do all the work and convince it. And we've done 75 pilots. You can do it in a small thing. But how do you do it system-wide? These are the big challenges that are the next on the horizon, I think.
Great.
I think I've had the month of my life in that respect, because 5 years ago, I was thrown out everywhere. It did not matter what hospital I showed up at, they just yelled. And then, this is not publishable. And this month, the 3 that has been the roughest rejections have all circled back, and they want to do research. And I thought to myself, holy smoke, the woman who was that angry? Like, how did she even wrap her head around this is a good idea? And I realized she has no idea it's the same thing. She has now, 26 studies on the microbiome. NYU has decided this is what we do. And then somebody went out and researched it and figured out what companies to touch. They have no idea it's the same
They always come back.
They always do, but it's like one of those things where you're like, you're up against something till you're not up against it any longer, because the market is changing really, really fast. But also, the patient autonomy is changing really, really fast. Patients now, like our patient protocol, just people have been undiagnosed for a long, long time. Then they've been on 3 cycles of biologics that didn't work, and now their liver or their kidney is failing, and they are 200,000 plus to their system, and they have nowhere to go. Like, they're yelling, but we also have the payers that are looking at the biologic drug costs going up, and saying, okay, so you have all of these wellness programs offering us, but what are you actually doing about the things that hurt? It's painful, which is like cost of biologics. And I think that's how we get to market, but it's very easy to sit here and talk about. It's very hard to do in practice.
But much thanks to people like Chris, et cetera, who are out in front and starting to blaze some of that trail, because
Took the initial hits.
Just come and punch me afterwards.
But there is some lights at the end of the tunnel in a
sure.
number of these areas where it seems to be there's a number of organizations that are starting to make, there are initiatives in organizations that are making the prescribing process easier, the remote patient monitoring codes, which a number of our products possibly could use and eventually may be able to use, or allowing providers then to bill for reviewing some of the data, et cetera, coming from the products. And so I think in the general awareness of even having a chart that with an industry, that exists, I think is helping out. So it's an evolution of things in healthcare. So it's not fully bleak because of people like Chris, but it's still some gaps there for sure.
But I also think we're different in the sense that, sure, normal financial exchange is that somebody pays for a product and then we deliver a product. But because we're digital therapeutics, we need data. So if we have clients coming to us and saying, we love what you do, but we really don't want to pay that much, we're like, that's fine. 100% at risk, we'll deliver the product. If you actually save, we'll take 40% of the savings. And they're like, that would be a lot of money. Yes, but you can either pay up front or you can pay on the backside. And then, of course, you pay a premium. But I think it's a very different economy, right?
Yeah.
Yeah, absolutely. One of the things that we talk about a lot is, our company being kind of half healthcare and science, half entertainment and tech. We're always trying to kind of embrace the diversity of that, because those are very different industries that do things very different ways. And one of the things that comes up daily is trying to pick the right things from each of those sides, right? And oftentimes, there is no precedent. Actually, most of the time, at this point, there is no precedent. We're saying, how are we going to solve this? Let's see how someone else did it. Well, maybe Chris did it. But usually it's kind of like,
tell you
all
a bunch
right.
of ways that don't work.
Yeah, right, exactly. And that's exactly kind of the point that I want to make, is one of the things that we do lean into heavily in the tech and are still not amazing at is being comfortable with being uncomfortable and releasing something, getting it out there in the real world. Clinical trials are wonderful, but they're not the real world. Getting out there, getting data, reacting to that data quickly, failing fast. Things are going to break. That's okay. But the sooner they do, the sooner you can fix them and make them better. And that is very different from kind of a pharma model and a way of thinking and a product release. So a lot of what we're trying to do is embrace that side of things and get us all just okay with that and to get stuff out and try it.
Yeah. I mean, and the counter argument, though, is like sometimes like you can't do that experimentation because lives are at stake. So it's like knowing how to actually communicate where you are in terms of evidence and like where you are in terms of your product is super important for managing expectations. I think, Owen, you have some thoughts around that.
Yeah, I mean, you're also limited by FDA if
you're going that route.
If you're going that route, you can only change the algorithm so much, and sometimes you can't. On certain things, and so that will be actually the FDA. Some of you may know this, came out with an AI machine learning sort of concept paper sometime in March or April, which proposed some ways to deal with this that aren't final, but things like creating like an algorithm change protocol that you follow post-market, or different ways to experiment with things. So exciting stuff, but still unclear of how that may play out. So it is tough, Also tough because we're in our pivotal trial now, 5 sites, a number of patients. We're going to learn a lot about how to make the algorithm better, but we may not be able to do that. We may have to release the one that's less good because of the regulatory.
Well, what's interesting, I think when you think about pharma and biotechs, and there's some buzzy terms around like real world data and like real world evidence, and there's typically a disconnect between sort of the pharma companies like wanting to know how their patients are doing, and needing to sort of like run additional studies, phase 4, develop registries. I think what's also really unique here is as you think about products launching and being on the market, you already have access to a lot of this data around how patients are experiencing the product, how they're benefiting from it, Are they hitting their outcomes? And so how do you, and I think we only have about maybe 1 minute left, maybe one of you can kind of shed some insight in terms of how do you think about kind of real world data and real world evidence in the context of, hey, we're already capturing a lot of that.
I mean, I can go. We have a lot of patients out there. We collect a lot of information. I think the most interesting is we work with a lot of pharma companies, so most of the respiratory pharma companies. And when we started, it was, okay, you guys are great at tech. We know these patients better than anybody, so we're going to tell you what they need. And honestly, really quickly, they came back and said, you guys know these patients way better than we do, because we're surveying them all the time. We have a lot of information about what they're doing in the product, what triggers they have, what they're adding, what they're calling in to complain about. And that was fascinating. And so now they've seen it as this opportunity to collect data very, very quickly. Yeah. And so we can enroll people really quickly. We can build in surveys. They can get data that it's kind of like a candy store for them now. They just want to play and collect.
And they use it for segmentation, right? So instead of them actually, they're not necessarily at a place where they want to offer it as a companion to their drugs or anything, but they definitely want to use our products for their trials. Because for their trials, they need to understand how can we actually lower the amount of people, the segmentation, all that stuff. And I think one of the things that we find interesting when it comes to the iterative process is that if we find something in the data of one patient, if there's no harm to it, we can take 10 patients tomorrow and run that same experiment. If 9 or 10 out of those 10 actually come back with a positive, we're going to do that again, which means that a lot of times when we now get the questions around, like, so what do you do with activity and sleep and whatever, we're like, we don't even think about those things, because we know if we do these 3 things, it'll fix this thing over here, and we have data to prove it. So I think that's actually where the real world evidence come into play, is that these people are treated as an N of 1. We get them, they get themselves, and then when you line them up next to each other, then we actually start understanding the populations, and that's where you create the insights that are not just going to make our products better, but it's fundamentally going to change the way that we consider medicine today.
That's great. That's amazing. And we're getting double red signs back there that we're up on our.
Hey, Bev.
You guys don't see that, but we're seeing them. So that's great. Thank you so much. I think let's introduce sort of another quick poll question. Let's see if I can bring it up here. So now that you've heard some of this, how frequently do you believe your organization will use digital therapeutics for patients? So get ready. 5, 4, 3. Hope you kept your phones out. 2. All right. What do we have?
All right, we got some time.
Okay, we've got a little bit of green.
So who said never? Raise your hand.
Get out of here.
Yeah.
They're already leaving.
You learn the most from the outliers.
Yeah.
So no, that's great. So I think we got some more sometimes. Well, it would be really interesting if someone changed their mind after my saying that. But I think
One did.
One did. Oh, nice. All right. So who's that person that remains? No, but thank you. This is really informative. And I think we'll open it up.
Yeah.
Questions?
First of all, we're going to give you a round of applause for a great job. And just to put a little pressure on, we have 16 questions, and they're great. So I'm just going to start reading, and you can choose who answers. But I've never seen so many questions. I'll just share that. Is this really affordable for individuals and/or employers to digital therapeutics?
I'll take that one. So it has to be. So the bar is higher for us than med tech products and drugs. So we have to prove both clinical utility, we have to prove the ability to implement, and we have to prove ROI in every single organization that we work with. And if we can't, they won't go forward. And so we spend a lot of time on the pricing and how we're going to do it and what impact we're going to have. But it is absolutely like table stakes to prove ROI. You can do a pilot, but that pilot has to show it or it'll be dead.
Oh, a live audience question.
So it depends on the stakeholder. For a lot of the health systems or the payers we're looking at, it's pretty much cost and utilization. So they're looking for reduction in hospitalization and ED costs is the primary driver. We work with a lot of pharma companies, and over there it's obviously completely different. They're looking for lift and fills and adherence.
So we take 2 years of data prior. And so we have very sick patients that we reverse disease on. So we can actually very easily, I'm an economist by training, take 2 years of data, you figure out the healthcare utilization, RX, and then you have the savings. But what we've seen in our data, which is interesting, is that 36% of the people going into the program have scheduled surgeries that get canceled. So we're talking back surgery, neck fusions, knee surgeries, and so on. So we are definitely hitting on a lot of different metrics. We don't get anything for canceled surgeries today. We only get on heart cost reduction.
I should add, we spend a lot of time on CQMs and efficiency. They're just much harder to measure and model, but those are factors also.
Okay, next question. And this is a good one as well. These are all very niche companies and apps. Do you anticipate consolidation in the industry?
I was on a panel about this that Mette sort of moderated last year. Likely consolidation. I think industry needs to maybe grow a little more, and then as a couple of companies likely get out in front with large-scale commercial success, I think that, I mean, these are like buzz terms, but the infrastructure will allow them to kind of merge with some of the other companies along the way. So certainly, I'd imagine there would be, there were a lot of point solutions right now, like working on walking, et cetera. Dream of the time where if I work with a stroke patient, we could help out with cognition, walking, and language all within the same solution, so they don't need to have 3 separate ones. Yeah. But I think we need to evolve to get to that point.
And it's starting to happen. One of the companies, Livongo, that just went public, they're not doing as well as Health Catalyst, but they've already acquired a couple of companies in different domains, and they're trying to use that leverage.
Have payers embraced digital therapeutics? And if so, which ones? I would be curious to know.
I can go there. We pitch the commercial payers a lot. So they have and they have not. And so when they have, what they're trying to do is use it as a new age disease management program that identifies super sick people. They want to go around physicians, frankly, and go direct to the members. The employer as the payer has probably been the biggest to adopt. There's a lot of companies that are going direct to employers. And now for the first time, we have Medicare, it was already mentioned, around remote patient monitoring. You have CMS paying for RPM, and that's been the source of a lot of discussions anyway, and things are starting to happen, so it's starting, yeah.
Yeah, there's a few examples of, in CPT code land of digital therapeutics able to bill for certain interventions. There's a few examples in sort of HCPCS medical benefit, at least 1 or 2 I can think of that are working on there, and there's others that are making some progress on a pharmacy benefit, and I think it depends on a lot on where the product's administered, what kind of population it has, how the treatment works. These are all one-off and not sort of regular or predictable yet, but there seems to be more and more traction that eventually someone like CMS will need a strategy as it relates to
absolutely. The trends are good, but it's still early. Yeah.
What's your one wish with respect to regulatory hurdles that would get these tools to patients faster? That's an interesting question.
Yeah, so it's interesting. One wish I think it's more, the regulatory pathway is fine as is in the beginning. I think it's more the post-market, that is the problem. Or going to be more the problem, like what you're allowed to do after that point and how that works. I think that. I get really excited about in post-market the ability to use some of our data for sort of real-world phase 4 submissions back to the FDA, because in our case, our primary endpoint, we're actually collecting in clinical grade as a result of delivering our digital therapeutic, so we can do that. So I actually think the FDA has done a fairly good job from now into market perspective, but I think afterwards we're going to have some learning curves that we'll need to go through.
Drugs don't change and get better. FDA has to figure out how to deal with that.
Yeah.
How do patients find out about digital therapy that might benefit them? And I am a provider. How do I find out about them as well?
I can go through. Most digital health companies have tried every possible way because there isn't, a built mechanism. So we have 2 primary ways. One is direct to patients. So we do a lot of Facebook acquisition. We acquire a lot of patients off of Facebook and have gotten pretty good at that. The other is through clinician referral, and often there we're going to an IDN or large health system. So we sell at the top, and then pushed down to different physician groups, medical groups, and docs within that health system, and then they refer people into Propeller. But that's where the jankiness comes in. There's no like clean way to do that. Sometimes they're handing a flyer. Sometimes they're sending an SMS. There's just a lot of mechanisms. Nothing's perfect.
For us, it's definitely the insurance brokers that cover the self-insured companies that are the best way, because once you do well with one, then they sort of have the pipeline for you. But like you, most of it is through Facebook and social media and stuff like that.
So this next question is about direct-to-consumer marketing, and I think you've brought that up. Anything else you'd add on that question? How?
I think you probably.
Oh, I was just going to kind of underline the iterative process there. I mean, you hear it, you guys are pretty far ahead, but we still don't know all the answers. We still don't know how this is going to look in 10 years, right?
Right.
So the sooner that we can get out and experiment and try things, the better.
But I think at the end of the day, we're all consumer companies, because I might sign on Nielsen or some company, but at the end of the day, they sign on as a client, but unless I can recruit their members, I actually have no assignment. So at the end of the day, we all operate like we're consumer companies, but we're just doing it through a different channel right now. And I think over the next years that will change.
But I mean, it's a tough loop because for us, we're going the prescription route, and we will need some sort of coverage. For example, if we were to do, since we use music, like an Elton John commercial that went all over the place, that people would connect with, like could really tell the story, like could even go fairly viral, we may not be able to get either a prescription for that patient or coverage for it, and we don't want to get out in front of those mechanisms, have a bunch of people come in and say, well, we can't really help you right now. So that's sort of a catch-22 right now.
As to the theme we've been hearing this morning, how much data is generated? Where is it stored and who owns it?
So in our case, the patients own their own data. We actually believe that the privacy of the patient is important. So if a patient of ours say to us that they need to scratch all data, we have a delete, but they won't have access, we won't have access, it's scratched from everywhere. But I think in general, we're all hoarding data, right? Like that's how we are making this happen. So I think we're all extremely protected, HIPAA compliant, and all the other fancy words that I can't remember. But essentially, that's the name of the game, is the data. So we do whatever we can to earn the right and deserve to keep that data.
The hardest discussions we have are around data rights. Not data ownership's kind of a weird concept, like they're on our servers, who has rights to it? And that is what we get into with every health system, every payer, every pharma company is around rights and who has rights to do what with the data. It's very complicated, but it's starting to normalize a little bit.
Yeah, and it's something we all need to be as thoughtful about as possible, because I imagine that line of what's acceptable is going to shift, more and more towards protecting the patient and or people in general in data over time. And we want to make sure, we are all patient-centric companies. We want to make sure that we don't get caught in a place where we look like villains doing something that's standard now, but in the future becomes bad. So we think about this and talk about it a lot, like what is the right thing to do in this case?
Yeah, I would just reinforce that it's something that we all discuss a tremendous amount, take super seriously. We have an amazing opportunity to use this data for extreme pure good, right? And I don't think any of us are sitting here like, oh, how can we get advertising dollars off that data? That is not why we're even considering it.
We're still pretty little companies. Like one bad breach could ruin your company.
Yep.
So this is sort of life and death for us.
Yep. So you're right. It comes back to that legitimacy and responsibility.
Probably one, maybe two more questions. We're nearly out of time. What are the challenges in reaching your target patients, and what strategies have helped and have failed?
Chris?
So we've tried a bunch. So the ones that have been successful, so when we go through docs, it works really well. We have really high conversion rates. It's just really hard, like everything, to keep the clinic focused and identifying patients and getting them in. It's a pretty traditional med tech pharma problem. Facebook has been really, really good for us, but we have the same problem. How do you get coverage on those patients? Who's actually paying for them? And so that is hard to navigate. The place where we've struggled the most is really with direct, payer programs that are direct to member, where we're sending mailers out. What they're trying to do, list-based marketing is very, very difficult. And so it impacts this audience a lot, because a lot of times the payer is going to come in and say, well, I want this specific named list of patients on. That's super hard to execute often, or at least it has been for us. And same thing, it's like I'm in some kind of pay-for-performance arrangement, so I want these patients on. It's very hard for a clinic to treat patients differently. You end up with a list. It's very, very challenging.
And I've heard that story from 3 or 4 other digital therapeutics companies.
We actually have a funny story. So we're doing, currently with the health plan, we are treating RA, ulcerative colitis, and Crohn's on paper, except we have 89 different disease states in that trial. Because for some reason, on their end, there was a little bit of a glitch, and they apparently didn't know how to segment their own population, so they sent it to everything. So we have lupus, scleroderma, whatever, it's all in there. It's just like a hodgepodge. And we called them and we said, you are aware that you are sending all those patients that does not fulfill the requirement, but we don't want to be the ones that refuse your clients. We're happy to take them, but it's like, but it just says something, right, that could even happen.
We need to end. We could sit here. We could sit here
How many
all
did we
day.
get through?
But the panel has agreed. We have lunch now. The panel has agreed to stay up here and answer a few more questions. So if your question was not answered, please come on up. Let's give them a round of applause.
Thank you, everybody.